Welcome to part one of two presentations on the hand. In part one, we're going to focus entirely on the fingers. So we will review some normal anatomy very quickly, and then we will use clinical cases to look specifically at the fingers. Here are some of the learning resources used in the creation of this presentation. Here we have a standard AP, DP view of the hand. Just take a few minutes, maybe pause the video, just to remind yourself of the anatomy before we go on further.
Fingers are made up of complex ligaments and tendons. On this image, we're looking at the dorsal aspect of the finger, and specifically, we're looking at the extensor mechanism. Now, our extensor tendons straighten the fingers by connecting muscles of the forearm and the hand to the bones in the fingers and thumb. The principal tendon, this is our long extensor tendon, and it divides proximal to the proximal interphalangeal joint into three separate slips. This middle slip, this inserts into the base of the intermediate phalanx. The lateral slips, these pass distally on each side of the phalanx. Now these lateral bands are bound to the middle slip of the extensor tendon, but there is a space between these lateral bands that is elliptical in appearance, and it's often likened to that of a buttonhole. The common tendon then inserts onto the dorsal surface of the base of the distal phalanx. Now our flexor tendons, these run inside tunnels at the wrist and the fingers. And if we look at the bottom picture, we can see that the flexor digitorum superficialis tendon, and more importantly, the flexor digitorum profundus tendon, is located on the anterior surface of the fingers. And these are responsible for bending fingers, and the way they act is very similar to that of a bicycle brake cable. Our collateral ligaments, these extend from the lateral margins of the head of each metacarpal. So if we look here, and these then run across the metacarpal phalangeal joint and into the base of the proximal phalanx. Our middle collateral ligament, this extends from the lateral margins of the head of the proximal phalanx and then extends into the lateral margin at the base of the intermediate phalanx. And lastly, the distal collateral ligament, this extends from the lateral margins of the head of the intermediate phalanx and inserts into the base of the distal phalanx. On the volar aspect of the joint capsules, of the metacarpal phalangeal joints and of the interphalangeal joints, it's made up of a very dense fibrous structure called the volar plate. Now the important thing to understand about the volar plate here is that the distal portion of the volar plate is really firmly attached to the volar plate at the base of the phalanges, and that's why when you get injuries to the bases on the volar aspect, it's always the volar, the distal portion of the volar plate that gets ripped off. But we'll look at that in a little bit more detail in a moment. So with the fingers, the classic mechanism of injury is a direct blow, hyperextension or hyperflexion, rotational injuries, and of course crush injuries. When we undertake image interpretation, we use the search strategy AABCS to enable us to remember to check each area carefully. The first A stands for adequate. Is the image adequate? Do you need to do further views or do you need to repeat? Now, I would encourage everybody, despite what your protocol may say, is to do 3 views for finger imaging. And the reason being is that because of the tiny fractures, you may only see a fracture on one view, and it might be the oblique view, or it might be your lateral or your PA. And certain injuries are only best appreciated on one of those views. So if you only do 2 views of the finger, you have a higher risk of missing a fracture. And this is really important. I think we're always a little bit glib about finger x-rays because they're very quick, they're very easy, they're not particularly challenging. However, if you miss a tiny finger fracture, you can end up with significant deformity and permanent disability. And this is really very key because if you think about it, we use our fingers to do so many things on a daily basis, and to end up with a lifelong disability just because for the want of doing one further view to be able to pick up that fracture isn't really appropriate. Okay, so the next one we want to look at is alignment. Do all our bones stack up? So is each phalanx in alignment with the one below? Is the proximal phalanx in alignment with the metacarpal? B is for bones. So check the bones very carefully. There's a lot of overlapping structures in the hands and the fingers, and so you can frequently miss a subtle fracture in the cortex because you haven't gone around each and every bone. Check the trabeculae. Is it all normal? Do you have any increase in sclerosis which might indicate an impacted fracture? And look for any lytic lines, and this might indicate that you've got a fracture. The next thing to look at is cartilage, which stands for joints. So are the joint spaces a uniform width, or do you have diastasis on one aspect, or even do you have loss of the joint space, which may be because of osteoarthritis, or may even be because of a dislocation because you've lost that normal appearance. And finally, soft tissue. Look for your soft tissue signs. This can be really helpful because it might only be the soft tissue swelling that helped guide you to the area of interest. The 3 main finger deformities that we get are a mallet finger, a boutonniere deformity, and a swan neck deformity. And we'll have a look at these different radiographs in a moment. A boutonniere deformity consists of flexion of the proximal interphalangeal joint with associated extension of the distal interphalangeal joint. It occurs when that central slip of the extensor mechanism ruptures. So what happens is that loss of the extensor mechanism leads to the proximal interphalangeal joint flexing, and that ruptured central slip protrudes between those 2 lateral slips. And these lateral slips then displace vola, which causes the distal interphalangeal joint to go into extension. Now, it's rare for this injury to be associated with a fracture fragment, but if it does, the fracture fragment will be located at the dorsal aspect of the base of the intermediate phalanx, and that will confirm an injury to that central slip. So what is it? It's a boutonniere deformity where the proximal interphalangeal joint and the distal interphalangeal joint of the right little finger. How? There's flexion of the proximal interphalangeal joint with extension of the distal interphalangeal joint. Swan neck deformities are rarely caused by trauma. You usually find this deformity in individuals who are ligamentously lax, such as those with rheumatoid arthritis or systemic lupus erythemus. And what happens is that with a swan neck deformity, it's the opposite of a boutonniere deformity. So with the swan neck, you get extension of the proximal interphalangeal joint with flexion of the distal interphalangeal joint, and it's meant to look like the appearance of a swan's neck. So what is it? It's a swan neck deformity where proximal interphalangeal joint and the distal interphalangeal joint of the left little finger. How? So there is extension of the PIPJ and flexion of the DIPJ. So mallet fingers are caused by the avulsion of the extensor tendon, and this is at the insertion of the dorsal cortex of the surface of the distal phalanx. Now, a quarter of all cases are associated with avulsion fracture. It's so called a mallet finger because of the characteristic flexion of the distal interphalangeal joint. And what happens is that it's caused by a direct blow to the end of the finger, causing the finger to forcibly flex whilst the extensor tendon is still taut. Now, a word of caution. Not all dorsal fractures located at the base of the distal phalanx are avulsion injuries. Remember, an avulsion injury is where it occurs where ligament or tendon attaches to the bone. So typically, avulsion fractures tend to be quite small fracture fragments, whereas if, for example, a patient sustained a direct blow to the dorsal cortex of the distal phalanx, they'll end up with a much larger fracture fragment. And what happens is, because the extensor tendon hasn't been damaged, you'll actually get no flexion deformity. So what is it? It's a mallet finger deformity, where it's the distal interphalangeal joint of the left little finger. How? Flexion. So now this is our example of a patient who hasn't actually sustained a mallet finger. You can see how it could be misconstrued. This patient has sustained a direct blow, which has caused quite a sizable chunk of bone to be broken off. Now, it can be quite easily misconstrued as flexion deformity because you can see the soft tissue swelling looks like it's flexing forward. But actually, if you look at the distal phalanx, we can see it's perfectly aligned with the intact articular rim in perfect alignment of the head of the intermediate phalanx. So this soft tissue swelling shouldn't be misconstrued as a flexion deformity. So what is it? It's a fracture where it's of the dorsal cortex of the base of the distal phalanx of the right little finger. And how? Well, we can see that this fracture fragment has been slightly distracted, so we would use slight distraction in our how, and the fact that it is an intra-articular injury, because an intra-articular injury indicates that it's a much more significant injury than one that is extra-articular. The flexor digitorum profundus tendon is occasionally avulsed from its insertion at the volar aspect of the base of the distal phalanx. And it's called a rugger jersey finger fracture because it occurs when, for example, a rugby player, they grab another player's jersey. And when that other person pulls away, the tendon of the tackler then avulses at its insertion. Now, clinically, this patient will be unable to flex at the distal interphalangeal joint, because if you think back to that slide which shows you the tendons where they insert, what happens is that the flexor digitorum profundus characteristically retracts proximally to come to rest at the bifurcation of the flexor digitorum superficialis tendon. And this is located at the level of the proximal interphalangeal joint. Now, if you do have an avulsed fragment, this is where it will often be located, as with this image. But it's important when you look at these images that you don't misconstrue this injury for a volar plate fracture. So what you need to do is you need to, as always, go around the cortex of each and every bone, but you need to particularly scrutinise the volar cortex of the distal phalanx, and you will be able to identify the site of the fracture origin because you will have lost that cortex. So what is it? It's a muscular jersey finger fracture where flexor digitorum profundus insertion. How? Marked distraction of the fracture fragment residing at the level of the proximal interphalangeal joint. If we think back to earlier, remember that the joint capsule on the volar aspect is made up of a really dense fibrous structure called the volar plate. So this dense fibrous structure is really firmly attached to the volar aspect of the base of the phalanges. And so if you sustain a volar plate injury, this dense fibrous structure will rip off or tear off the bone that it's attached to. So a volar plate fracture will always be on the volar cortex at the base of one of the phalanges. And I suppose the most common injury usually occurs to the base of the intermediate phalanx. So what is it? It's a fracture where the volar plate at the base of the intermediate phalanx of the right index finger, and how it's undisplaced and importantly it's intra-articular. Okay, so if we think back to earlier, our collateral ligaments extend from the lateral margins of in this case the metacarpal to the base of the proximal phalanx, and at the lateral margins of the head of the proximal phalanx to the base of the intermediate phalanx on both sides, and then again at the head of the intermediate phalanx inserting into the base of the distal phalanx. And so when you get a volar ligament fracture, these can be really quite subtle. As you can see, it can be quite tricky to identify this avulsion here. So it's important that you scrutinise the area carefully. If you look at this particular image, you can see how there's significantly more soft tissue swelling on the ulnar aspect of the head of the proximal phalanx, which will help to guide you into that tiny avulsion fracture. Unsurprisingly, the DP view is the best view to appreciate these injuries. So what is it? It's a fracture where it's the collateral ligament at the insertion of the head of the proximal phalanx of the right ring finger on the ulnar aspect. How? Minimal distraction. We've now come to the end of part 1 of the hand presentation, and I look forward to catching up with you in part 2.